Welcome, everyone. Thank you for attending our Gutsy Learning Series event today on managing your IBD. My name is Sarah Gandaharian, and I'm the Manager of Patient Programs and Evaluation at Crohn's and Colitis Canada, and I'll be the moderator for the event today. Before we dive into our webinar presentation, and I'll introduce the speakers soon, we'll just go over some technical details. This session is being offered in both English and French. To access the French audio, you'll need to click on the interpretation option. It's a globe icon that you can find in the Zoom menu bar. And when you select, you'll need to select French as the language option. If you encounter any technical issues, with selecting the French option, please use the chat or the Q&A box found in the Zoom menu bar. And if you experience any other sorts of technical issues with the presentation or the video, first try refreshing your website browser or restarting the Zoom webinar app on your device. Then again, you can also share any concerns or questions in the Q&A box and we'll get back to you. And to begin, I'd like to acknowledge the rich history and heritage of Canada's Indigenous people. From coast to coast to coast, we recognize the ancestral and unceded territory of the Inuit, Métis, and First Nations people who call this land home. Through this acknowledgement, we express respect for the traditional territories of Indigenous communities and contribute to the promotion of reconciliation. Next, I'd like to also issue a disclaimer. This content in the presentation in the event today is by Crohn's and Colitis Canada and our expert speakers and is intended solely for educational purposes. While the information holds general value, it may not apply to specific medical or personal situations. And these online resources and events should not be seen as a substitute for the personalized judgment and care that's provided by a trained healthcare professional. So if you do have any questions, we'll do our best to answer this evening, or we may refer you back to your IBD specialist or primary healthcare provider to get your questions answered. And for those of you who are joining for the first time today, I'd also like to share Crohn's and Colitis Canada's commitment with you. Crohn's and Colitis Canada is dedicated to discovering a cure for Crohn's disease and ulcerative colitis. Through research, education, and advocacy, our organization also strives to enhance the lives of both children and adults affected by these chronic diseases. We really appreciate your interest in our organization and attending this event today, and we hope to make a positive impact in the lives of the IBD community. If you or someone you are acquainted with is affected by Crohn's disease or ulcerative colitis, we also invite you to explore our upcoming events where individuals can connect with others that know what it's like to live with one of these diseases. These are mainly virtual gatherings. We do have some upcoming sessions in December that you'll see up on the screen here. You're welcome to use your phones to scan the QR codes, and it'll take you to our website, which will give you more information and the link to register. If you are interested in attending more education events similar to the webinar today, you can also join us for our other upcoming Gutsy Learning Series events. We have one in the new year in January, which will be focusing on the Mediterranean diet for IBD and discussing the latest scientific evidence on this diet and its anti-inflammatory benefits for people with Crohn's and colitis. Then on February 7th, we will be covering the risks of cancer in Crohn's and colitis and discussing ways to help navigate these concerns through prevention and monitoring. And now, after going through the introduction, thank you for bearing with me. I'm really thrilled to introduce our two speakers for this evening. First, I'll introduce Dr. Ian Epstein. Dr. Ian Epstein is a gastroenterologist and assistant professor in the Department of Medicine and Division of Gastroenterology at Dalhousie University. Dr. Epstein is also the Assistant Dean of Professional Affairs in its Faculty of Medicine. He is the co-division lead for the Division of Gastroenterology and the vice chair of the Internal Medicine Specialty Committee at the Royal College of Physicians and Surgeons of Canada. Dr. Epstein was the recipient of the Young Alumnus of the Year Award from Dalhousie Medical Alumni Association, the Stephen Kubain Outstanding Faculty Residence Choice Award from the Department of Medicine, and was the 2018 Physician of the Year Award from Crohn's and Colitis Canada. I would also next like to introduce Barbara Curry, who is an IBD nurse practitioner in Halifax, Nova Scotia. Barbara graduated with a bachelor's and master's degree in nursing from Dalhousie University and started her practice in 2006. Her work is focused on IBD with a special interest in pediatric to adult transition, patient-centered care, senior care, as well as IBD care for marginalized groups. Barbara is a founding member of the Canadian IBD Nursing Group, also known as CanIBD, and is involved in many Crohn's and Colitis Canada initiatives, including the development of the IBD Conversation Guide, which we will be covering this evening with Barbara and Dr. Ian Epstein. She was also the recipient of Crohn's and Colitis Canada's IBD Nurse of the Year Award in 2019. And finally, we are thrilled to also have Natisha Lala as part of our panel today. Natisha is from Ontario, Canada, and she has been living with Crohn's disease since her diagnosis at the age of 18. Over the years, Natisha has experienced many complications associated with living with an invisible illness. And in 2018, Natisha was able to get her severely active disease under control. In an effort to use her experiences to provide support in the community and help raise awareness, she started volunteering with Crohn's and Colitis Canada that same year. She has participated in many Gutsy walks and has been a Gutsy support mentor at our organization. Natisha hopes that her volunteer efforts will help those in our IBD community feel seen, supported, and understood. Thank you all to the speakers for being here this evening to share your expertise with us. And thank you everyone in the audience for joining us. And I'll just pass it over to Dr. Epstein to please take it away from here. Thank you.
Thanks, Sarah. Feel free to go first name basis. I hope we can be as informal as this virtual format of a webinar allows, and I'll try to go casual and formal. And it's an honor and a privilege to be here and presenting with Barb, who I know well from our clinic in Halifax, and Natisha, who I'm looking forward to hearing from this evening. Before I get my slides and launch into my presentation, I'll just express gratitude for the invitation. It's a real honor to be invited to speak to a group sponsored by Crohn's Colitis Canada, which is such a valuable organization that I've been so happy to partner with over the years, and so grateful for all the expertise and support you provide for all the patients that we try to help here in Halifax. So thank you for the invitation, and thank you for putting me on such a great panel this evening. I think I get about 20 minutes. There's my Dalhousie logo. Hopefully that's visible to everybody, and I'll launch my slides. The first section of the webinar this evening and the first 20-25 minutes or so falls to me to take you through a sort of a rapid fire overview around managing your IBD and the highlights of what you should know. And we're going to start with a poll, actually. And Lucy, we're going first name. Hopefully you can help me with that. Launching the poll, and we'll give it about 30 seconds. Asking, everyone here, we have lots. It's really an honor to see over 250 people here tonight, to ask how would you rate your current knowledge around the management strategies for Crohn's and colitis. And there's no wrong answer here. This might be a new diagnosis or something you just happened to have read about, you wanted to learn more about, and you're just learning and you're at a 0, or this is something where you've been dealing with for years and you're at a 10. We're just curious to get a poll of the audience. So I'll leave that open for about 30 seconds, and then hopefully we'll see the results. So we have a nice spread here. Thanks for running that in the background. And it looks like we have everyone voting all the way from 0 to no knowledge, all the way up to a 10 out of 10. And the panelists could not vote, although I'm not sure I would put 10 out of 10. I feel like I learn more about this every day. But the majority are sitting there around 5 or 6 in the middle. And our goal for tonight is hopefully to increase your knowledge a little bit. The key areas around management fall into a couple of different domains. And as a gastroenterologist, and so the doc on the panel tonight and a gastroenterologist on the panel, the care that I try to provide and that we try to provide in our clinic, you'll hear more from Barb shortly, tries to be comprehensive, but there's no doubt from a doc point of view, it tends to fall into the category of treatments and medications more often than not. But that's really only one piece of the puzzle. And tonight, I want to try and take you through overview of a couple of different domains, not just medications. important really to talk about some other big areas around management and IBD, and those include four big domains, and medications is just one of them. Diet and nutrition is another big topic. Lifestyle, quality of life, social life, work, and then mental health, not just medications and gut health, but mental health and overall wellness is a really important area for us to chat about tonight and to think about in the comprehensive holistic management of Crohn's and colitis. I'm going to take you through a couple minutes on each of the three in the boxes here: treatments and medications, mental health and wellness, and lifestyle. Diet and nutrition, it's separate. You probably saw in Sarah's opening statements, there's a gutsy learning series in January on one of the diets that's anti-inflammatory, the Mediterranean diet. It's a huge topic, diet, and worthy of its own webinar. And sure enough, there's one in January. So I encourage people who want to hear more about diet to go to Crohn's and Colitis Canada to find out some of the information there and to attend that January seminar. But tonight I'm not a dietitian, so we're going to focus more on some of the other domains. So in a moment, I'll take you through some of the medication options and some of the other goals of therapy around mental health, wellness, quality of life, social life. But let's first talk about where the burden of IBD comes from. And the symptoms of IBD are actually broad. They're not all related to the bowel, and they're unique to each individual person. So although Crohn's and colitis are comprehensive diagnoses, for each individual's experience, it's a unique presentation. And so the symptoms include, but aren't limited to, the bowel symptoms of diarrhea and constipation and urgency, pain, gas, bloating, fatigue, bleeding, but also more systemic symptoms. We have a concept of extra intestinal manifestations. People can have manifestations of anal itching, irritation, nausea, vomiting, effects on their appetite, weight, nutrition, and sleep. And we'll talk also about mental health shortly. The management is often symptom directed, and this is an example of that. And so if you come to see a gastroenterologist or an IBD nurse practitioner or a healthcare provider with a diagnosis of IBD, we often will try to focus in on the symptoms and symptom management. Here's an example. If you came with constipation, we would try to figure out what's going on and is it a consequence of inflammation by doing some testing. We'd try to consider adjusting medications if we think the cause might be inflammatory. And we try and troubleshoot the symptoms with symptom management. And this is a generic statement. If you're struggling with constipation, the caveat at the top is only make treatment plans after consulting with your healthcare provider, as it has to be individualized to your situation. But in a general level, we try to treat symptoms of constipation with fiber, water, bulking agents like Metamucil or other laxatives, and stooling patterns like not holding your stool, not straining, and concentrating on pelvic floor exercise and evacuation. Another example might be fatigue, not as specific a bowel symptom, but again, we would try to sort out, is that due to a flare? Is it due to gut inflammation? So you're going through testing, you're looking at blood work, scopes, we're adjusting medications for management of the inflammation as needed. We're looking at other conditions that might cause fatigue. We might check your thyroid, for example. And then we might look at deficiencies in nutrition. Common ones in IBD might be B12, iron, vitamin D. And then we think about other causes that travel with IBD, and a lot of that is mental health and wellness. So think about depression, anxiety in your sleep, and targeted treatments to try and address those symptoms. So I hope those two examples gives you a sense of how the clinical presentations and the common symptoms of IBD helps direct investigation and management. For the anti-inflammatory component of it, and for the broad overview of how we try to medically manage Crohn's and colitis, the goals of therapy are to reduce and control the inflammation. And as a consequence of that, improve some of those symptoms we've been talking about, and then improve your quality of life. And so through the medical management, the goals of that therapy are really directed to reduce the inflammatory burden, either directly through anti-inflammatory medications or through immunomodulatory or immunosuppressive symptoms. And that's because Crohn's and colitis are autoimmune diseases where your own immune system has become hyperactive and causing inflammation in your own gut. And so immunomodulators and biologic agents that block signals within your immune system are the types of medications we use. They fall into certain classes, and here's just some examples. Sarah said right at the outset, we're not endorsing any specific agents tonight. This is not an exhaustive list. We're not saying these are the drugs you should be on. These are just examples of commonly prescribed medications you might see that fall into the classes of what I've been discussing. And so some of the anti-inflammatory 5-ASA compounds are listed here that are often used in ulcerative colitis to treat mild to moderate ulcerative colitis, to treat the inflammatory condition in the bowel. For immunomodulatory medications, methotrexate, azathioprine, some of the brand names like Rumitrex and Imuran are used. Steroids for flares, prednisone is a term you may have heard about, or budesonide. The brand names can be listed here, Winpred, Entecort. There are other types of steroids brand names on the market. We also use these 4 classes of medications commonly for the management of the inflammatory autoimmune disease as well. And these are drugs that will block signals in the immune system that are implicated in the cause of Crohn's and colitis. And so biologics, which are injectable medications through intravenous or subcutaneous injections, have been around for many decades, and Humira and Remicade have probably been around the longest. There are others on the market. One example is Entyvio. In the last couple of years, biosimilars, which are, I'm going to do air quotes here, not generic, but the concept is like a generic, but they're molecules that have been created that are similar to the originator molecules of Humira and Remicade, not exactly like a generic, but because of the fact that those drugs have been around for a while and may be off patent, companies have developed drugs that are similar. So those are biosimilars, and there's actually many, many more than are listed here. But you see some examples, and these are biosimilars for the Humira and Remicade originator products. The newest drugs on the block are oral, and there's 2 classes of those that are in the process of being approved or just approved for use for Crohn's and colitis in Canada. JAK inhibitors, Xeljanz and Rinvoq, and S1P receptor modulators, Zeposia. So these are drugs too that also block signals in your immune system, similar to how biologic might do it, but newer drugs that are available orally. So there's a broad overview of the classes of medications that one might see in consultation with your IBD clinic to try and manage your disease. How do we decide? Well, as I've said already, a lot of it is symptom directed, but a lot of it is also based on monitoring and staging and trying to figure out where the disease is active in your intestine. What are your symptoms? How active is it? And trying to have a custom made approach for each individual person. And we do that through a series of different strategies for monitoring. And that includes blood testing, stool testing, and in a couple slides, we'll also talk about scopes, X-rays and CAT scans, and importantly, your symptoms as well. So biochemical testing through blood work or stool sampling. And on blood tests, we look at your red blood cells, your white blood cells, your nutritional status, like your iron, your B12, your folic acid, and a blood test commonly done called C-reactive protein, which goes up in inflammatory states. Stool testing is important to rule out infections, particularly C. diff or Clostrid. You're going to make me say that. Clostridio. We'll just say C. diff. C. diff infection, which is something more commonly seen in patients struggling with inflammatory bowel disease. Fecal calprotectin is a kind of like the C-reactive protein of the stool. It's a chemical in the stool that goes up in states of inflammation. So it's a nice non-invasive way to get a stool sample and test for signs of inflammation in the gut. We also like to monitor disease activity and levels of inflammation by location, complications, other possible causes of symptoms, and look for signs of infection, anemia. So a lot of those tests I just outlined in the blood and the stool will do that. But to look for the location and other complications, we also need to sometimes move on and do more internal examination, looking inside the gut to see what's going on. And we can do that through scopes, or also called endoscopic tests, where, like in this cartoon here, a camera is put in most commonly the colon to do a colonoscopy, but sometimes also in the upper gut through the mouth, down into the stomach and small intestine, which can be reached from above, so an upper endoscopy. And then there's up to 15 feet of small bowel in between, and that can be looked at not with a scope, it's too hard to get through all those twists and turns, but through a pill camera called capsule endoscopy, but also can be looked at through x-rays, which can be done through barium, CAT scans, or MRIs, and in an emerging technology with ultrasound. I was actually just at a course this past weekend focused on trying to train a group of gastroenterologists in Canada to use ultrasound more broadly as a non-invasive imaging technique. Symptoms are also the other big part of that to track this. And you can track that at home on your own without any need to go through stool testing, blood testing, scopes, or imaging. And symptoms are really important for us to target our treatments and as a component of monitoring. It's not the only component. We don't go just on symptoms because sometimes symptoms can be due to other things, but it is a critical part of it. And so I encourage people, if they're interested, to look at the MyGut app to track some of your symptoms, including your frequency of your bowel movements, presence of blood, nausea, vomiting, pain, what you're eating, what your weight is, and how you feel. Here's a link to the MyGut app. Free, easy to use to track, understand, and manage your symptoms. And I know when Barb's going to be up in a few minutes, she's going to talk about ways to approach your appointments and discussions with your specialists around management of Crohn's and colitis. And focusing on a summary of your symptoms is certainly a good start to that. I know my time is not too much longer, so I'm going to go through some of the highlights around mental health fairly quickly, and then we'll finish up with some quality of life statements. So just a reminder to my earlier comment that mental health, wellness, anxiety, depression, these are all big players in the presentation of Crohn's and colitis. And why? There are multiple reasons for that, but one of them is a well-established connection between the gut and the brain. And it's well established now in 2023 that changes in the gut affect the brain, including how we behave and how we feel, mood, and anxiety. And it goes both ways. There are billions of nerve endings going between the bowel and the brain, and then backwards and forwards. And most of this is at an unconscious level. And in inflammatory bowel disease, the communication is disturbed by multiple chemical factors stemming around that inflammation. And that can affect a person's psychological state and emotional response. And in turn, stress, anxiety, and depression can trigger symptoms and cause pain to be worse and to persist. So it's important to watch out for signs of mental health concerns and talk to them, not be afraid to bring them up, not be stigmatized around it, and to recognize that it's a symptom and something important to talk to your healthcare providers about as part of the treatment and management plan. And so when you're keeping track of symptoms, it's not just how often you poop, and it's not just pain, it's also around mental health. And Barb's going to pick up on this theme in a minute around how you can have a conversation with your specialists. In fact, there's a prep guide and a tool that she'll present. Stress, anxiety, and depression, in summary, are common. Other emotional responses can affect quality of life too. You can have guilt around the disease, guilt around dependence on others to live your life, and feeling of a loss of control, guilt around feeling not reliable, having to have sick days, embarrassment and stigma around mental health, but also bowel health, and denial is part of this as well. And all of these can affect quality of life and management of the disease. Signs of stress in IBD may increase pain, cause pain to persist, can actually, in severe cases of stress, trigger symptoms and even potentially trigger flares. And it can be difficult to spot the difference between stress and anxiety. But in short, the symptoms are similar, but stress would be a more short-term response, while anxiety would be a lasting disorder. Excessive and persistent worry is difficult to control most days for 6 months or more would be a sign of anxiety, and it could result in psychological or behavioral traits like avoiding feared situations such as eating and drinking, and physical symptoms like pain, trouble sleeping, tension, headaches, stomach aches. And the diagnosis of an anxiety disorder would require at least 3 associated physical symptoms. Depression is also persistent every day for at least 2 weeks. So different from acute stress in that way. It's excessive, ongoing, and can interfere with everyday life. And psychological or emotional symptoms like hopelessness, guilt, worthlessness, lack of energy, or motivation, boredom, and trouble concentrating are all associated with depression. And physical symptoms like insomnia or hypersomnia, or changes in appetite and fatigue are all associated with depression as well. So to manage your mental health, some practical tips are be in tune with your mind as well as your gut, right? And take care of your body through healthy meals, regular exercise, plenty of sleep, daily routines, connecting with loved ones, things that make you feel connected, loved, healthy, and well. Healthy lifestyle, so avoiding alcohol, tobacco, and drugs, staying active and engaged, volunteering, mindfulness, relaxation, and speaking about it, as we've already mentioned. Mental health professionals are available and include counselors, psychologists, psychiatrists, nurse practitioners. You need to talk to your healthcare provider, and Barb's going to explain some of how to do that to get a referral. Some specialists may be available virtually, and there is no one-size-fits-all solution, but there are problem-solving techniques that are out there, wellness plans, treatment strategies, medications, and more. So it's normal to feel a range of emotions when receiving and navigating a diagnosis like Crohn's or colitis. It's important to recognize that it's not just about the GI symptoms and the GI medications, like I said at the outset of my talk. There's more holistic view that we're trying to take, and that includes mental health and wellness. Early diagnosis and treatment is important, and with supports from friends, family, and healthcare providers, you'll learn how to control the disease and live well with IBD. I'm reaching the end, Barb, so I'm going to turn it over to you shortly, but I have a few, maybe 5 minutes at most left, just around the impact IBD can have on social life as well, and quality of life. So you can imagine, with what I've taken you through in the last 15 minutes or so, talking about the GI symptoms and the mental health and wellness concerns, that there is a significant impact on IBD on the quality of life and social life. And people with Crohn's and colitis do report higher levels of social isolation due to factors like dealing with their symptoms, inability to join social clubs, having to catch up with work or school, and simple things like facing the anxiety of a washroom incident due to incontinence. So I also say, talk to your healthcare provider about this. Let us know about how it's impacting your quality of life. There's no one-size-fits-all solution again, but we can think about a treatment plan and medications that fit for you. It's because there's no one-size-fits-all solution, we need to go know specifically what's going on with you so we can have targeted interventions. For those struggling with urgency, for example, a bathroom plan before you leave the house may be something we could talk about. Strategies around anti-diarrheals before you leave the house, avoiding trigger foods, knowing where the restrooms are, being prepared with extra clothing or toilet paper. For some, it might be a strategy around exercising, and in general, light to moderate exercise is believed to not only be safe, but have anti-inflammatory effects and probably be advantageous. So learn what your body's capable of, talk to your healthcare provider about it, and take advantage of time to try and put some exercise into the management strategies. Give your time to adjust and be flexible around times like flare-ups. One other area worth bringing forward is whether there may be impacts on your work or school, and whether there may be notes required or accommodations required. And so your school or work may have an accommodations department to discuss it with. And if comfortable, you talk to your supervisors or teachers about that and your specialist, and there can be back and forth and letters, and there can be accommodations at school, for example, for meals, extracurricular activities, exams, assignments, washroom breaks, or at your place of work. And then my last slide is just remember you're not alone. Tonight's a great example of that. 293 people, look at that. So talk to your friends and family about your experiences and needs. Find support groups, and Crohn's and Colitis Canada is the flagship one. Download the Go Here Washroom Locator app and learn from Barb in a minute strategies to take to clinic to talk to your team about it. And with that, I'm actually going to stop sharing and turn it over to you, Barb.
Thank you, Ian. Just bear with me for a second. I'll share my screen. While I'm doing that, I'd like to also echo, no, that's not what I need to do. Share screen. There we go. Echo Ian's comments around thanking Crohn's and Colitis Canada for the opportunity to speak tonight. Oh, I apologize. my PowerPoint presentation keeps disappearing off my screen. So I just need to load that again. So just bear with me for 1 minute. We had it up and now it's not there. So just I'll bring it up again. That was a great talk, Ian. It's so, it's so apparent to us and for many people participating tonight that, living with a chronic illness is no easy task most days. And I hope that we can all learn from each other tonight. Now I'm not being able to share my screen again.
Barbara, if you want, I could always share it from the slide master deck.
Yeah.
I have to say next slide, next slide. It's not as easy.
Yeah, thank you, Ian. I'm just going to try one more thing here. And if that doesn't work, then we'll, I think we got it. Then we'll default to you.
You're good. You're up. I can see the slides.
You can all see my slides now? Am I on there? Okay, awesome. Sorry about that, folks. Once again, thank you all for participating in tonight's event. I have just a handful of slides because I wanted to take quite a bit of time in going through the guide that I'm going to present to you. Some of you here tonight may have been participants in developing the guide. There were focus groups of people living with inflammatory bowel disease, and maybe some of you watching tonight or participating tonight participated in that. And I think it's a great guide, and I look forward to sharing it with you all. So before we move on, I would like to just ask you this question. How often do you forget to ask an important question at a medical appointment for your inflammatory bowel disease? And that doesn't necessarily just have to be with your gastroenterologist. It could be with any of your IBD specialists. So I'll give you a second to answer that. Never, rarely, sometimes, most of the time. So we can see that very few people never forget to ask a question, and rarely, 17%, 57%, so more than half sometimes forget, and 24% of the people forget most of the time to answer an important question that they had been thinking about before going into the appointment. All right, so we're going to dive into the guide a little bit more, but I just wanted to show you what the entire page looks like. So it's a one-pager, but it's front to back. And again, this guide was developed by people living with inflammatory bowel disease. So I really believe it's reflective of the concerns and the lived experience of people with inflammatory bowel disease. Just to clarify, in my introduction, it said I've been nursing since 2006. I've actually been nursing since 1987. I've been an IBD nurse practitioner since 2006. So I've got 36 years of nursing experience, and I can tell you that I really believe that this guide is reflective of living with IBD and hopefully will help shape some of those important conversations moving forward. And sharing information about the physical, the mental impact, the emotional impact, the social impact, as Ian mentioned, can be very difficult. There's a stigma around the bowel, and it's not something we talk about. It's not so much Crohn's and ulcerative colitis, it's talking about our bowels. In our culture, it's not something we do all the time. So the ability to focus on the areas of your life that are causing you the most concern is a great way to co-lead your appointment. And in 2023, the buzz, particularly in inflammatory bowel disease, is shared decision making. And what does that mean? It just means that the person living with inflammatory bowel disease is feeling like a partner in the decisions that are being made about how to proceed with their treatment or their care in general. So we're going to get more into this, and you're going to be able to see it on a bigger screen there. So this is the first part. So this, again, this can be a PDF. You can download this from Crohn's and Colitis website. You can, I'm not sure if we have the ability yet to make this electronic so that it could be sent out in advance of your appointment, and it could somehow be uploaded into electronic medical records. We've had some baseline discussions around that, so that when you come for your appointment, you can bring it with you, or perhaps it can already be uploaded into your care provider's record. But either way, we'll take a look at it here. So the first part of the conversation prep guide looks at physical symptoms. And there's basically just 6 questions here. So on a scale from 1 to 4, 1 being no symptoms, 4 being severe, in the last month, my IBD symptoms include stool urgency, stool frequency, more than 3 times a day, bloody stools, abdominal pain, fatigue, and other. So in those boxes, you can tick off 1, 2, 3, or 4, 4 being severe symptoms, 1 being hardly any symptoms. And when you come to your appointment, if you have 4 for stool urgency and bloody stools, that should direct your appointment. Very quickly, we could see that, in the last month, your stool urgency, frequency, bloody stools have gone to a 4, where, last time I saw you, they were at a 1. Something's going on. We need to look into this. And as Ian had mentioned, there's various ways we can do that. And you're probably familiar with some of those now. The second part of the tool, and we're going to get to it after this slide, looks at discussing your mental health with your care provider. And as previously noted, a lot of people struggle with discussing their mental health and the impact that living with a chronic disease, a chronic gastrointestinal disease, has on their quality of life and their mental health. And we know from many, many research studies published that people living with Crohn's and ulcerative colitis have a higher rates of anxiety and depression. Talking about living with IBD affects your mental health, how it affects your mental health can be difficult. Few people talk about bowel functions. Certainly we don't talk about it a lot in public, leaving people with IBD feeling quite isolated. Particularly at work, where, somebody might be wondering why you need to go to the bathroom every half an hour, or why you're in there a long time, or why you get to work from home and somebody else doesn't. So there's all kinds of impacts that IBD can have on your daily life. The tool we're going to discuss this evening could provide you and your specialist a starting point to discuss how living with IBD is impacting your mental health. Discussing the impact of IBD on your intimate relationships is difficult. Many of my patients take a long time to tell me that, they and their partners are not intimate because of the concern around maybe fecal incontinence or fistulizing disease, all kinds of reasons why it's difficult to be intimate. Maybe they have a new ostomy and they're not sure whether their partner is going to accept that. The ability to discuss these sensitive topics and identify possible resources is greatly appreciated by people who live with IBD every day. So with that, the next part of the conversation guide really focuses on mental, emotional, and social impacts of IBD and its effect on you as an individual. So you can see on my left-hand side of the screen, in the last month, I've missed X amount of days of work or school. I've missed X amount of social or family events. I've had X amount of bowel accidents. I have or I have not avoided travel away from home because of my IBD. I never or occasionally, often, constantly worry about future flare-ups, even when I'm feeling fine. And again, I never, occasionally, often, or constantly experience general stress or anxiety in my day-to-day life because of IBD. So depending on how somebody would fill this out, can again focus the conversation on, oh gosh, you've missed 14 days of work in the last month. Tell me what's happening there. You know, you've had 2 bowel accidents this month. Let's explore that a little bit more. And then on the other side, on a scale from 1 to 4, with 1 being no impact and 4 being severe, the impact your IBD has on your social relationships, your intimate relationships, your career and education opportunities, and then everyday responsibilities like housework, childcare, shopping, and then again, your mental health. And then there's a little box there. I mean, obviously it's not a lot of space, but it's enough for you to jot down some quick thoughts about how your IBD has been impacting your mental health. And then finally on leisure activities, and then other. And other can obviously be anything that's important to you. On the back page, there's some questions around the main thing. What is the main thing your IBD is holding you back from doing? So, for example, again, on the right, there's some examples there. But maybe you want to go on a trip and you're worried about taking your medications with you. Maybe it's not always, I'm worried about having a bowel accident. I want to move to another country. Will I get my treatment there? I'm looking for some extensions on some exams or looking for some adaptations. How can I do that? And then if you could only discuss one issue with your nurse or doctor at your next appointment, what would you like to prioritize? Because as you can appreciate, some days there's multiple things you want to talk about. Your appointments are, you know, X amount of time, and we have to make sure that we're addressing the things that are important to you, that are impacting your life the most, as well as from a medical symptomatic perspective. Are we meeting our targets of reducing inflammation? So we have to balance all of that with obviously what's important to you as a patient. There's a section to list your medications, and that's always helpful because they change. Your primary care provider may change some meds. You may be seeing other specialists. So it's always good to have an updated list with you. And then finally, moving down the back page, on the flip is other helpful questions to ask during your appointment. So maybe these are the questions that maybe you might forget about. What were the results of my tests, my biopsies, my fecal cal or imaging? What are other treatment options? How do I know the medication is working? What is the backup plan if it stops working? And then sections for additional notes. So these are some of the questions that could come up in an appointment. Maybe it's something that's really bothering you and you want to talk about. You want to talk about the impact of bowel accidents on my work and personal life. How can I approach this situation? Maybe another question might be, I'm feeling anxious about going out in public and I'm unsure how to bring this up with my IBD specialist. So if we go back to the conversation guide, you could see that in the areas here that we've already highlighted, there's parts that you could bring up, like I've missed how many social or family events because of my IBD. I've avoided travel. I worry about flare-ups. So depending on how you rate that, it may be a good way, a segue into bringing up those questions that we talked about right here. So what I'd like you to think about now is, how do you see this conversation guide being the most useful? And there's going to be a whole host of options for you to choose from. And you don't have to choose just one. You can choose as many as you think are appropriate, or where you find this guide possibly being the most useful to you or to somebody you know who's living with IBD. So I'll give you a minute to take a look at those options. Okay, let's take a look at this. So at any appointment, 81% of you are saying that you could use this at any appointment. That's really encouraging because I do tend to agree that no matter where you are on your IBD journey, there's always going to be questions that need to be asked. And sometimes having something that can condense those questions down, focus it quickly in your appointment, and target the areas that need to be targeted first is very important. When first diagnosed, great. During a flare, yes. You know, when you're feeling well, I always like to say to my patients, when you're feeling well, I want you to forget you have IBD, if that's possible. And when I hear a patient say, you know what, I feel so good that I can't even believe I still have IBD, it just makes my day. But to be able to do that during a flare and focus on the points of conversation that you want to address is really important. When changing is there any way, Lucy, we can have the responses put back up? I don't know if that's possible or not. Just the percentages. Oh, yeah, it was there. Perfect, thank you. When changing it or changing treatment or assessing response to treatment, great. When changing specialists, and only one person said they wouldn't use the tool, and maybe this person feels that their disease is in remission and it's not something that they see themselves doing. Either way, it looks like from your responses that you see value in this tool. So the QR code is there, you can scan that, and you can download a copy of the conversation prep guide. You can start to use that in your appointments, and it would be great to get some feedback. I'm not sure whether or not at Crohn's and Colitis we could set up something where people could provide some feedback to us on how the prep guide was received with their care provider. And we're going to be doing some work around that as well through CAN IBD, helping all of our colleagues, not just our medical colleagues, but also our nutrition colleagues, our psychology colleagues, in appreciating this prep guide. Okay, I'm going to pass this over now, and thank you all for your attention. I will stop sharing my screen.
That was great. Thank you so much, Barbara and Ian. That was a really, really informative presentation and an overview of all the key areas of management. We did share a copy of the conversation guide in the chat. So if any of you have seen that already in the chat there, you can click on the link or copy and paste the link in your website browser. And yes, to follow up on what Barbara mentioned, Crohn's and Colitis Canada we'll be gathering some feedback. So if you do have feedback about using this conversation guide, or if you have any other questions, please do email us at learn@crohnsandcolitis.ca. We'll share that email address in the account and then under the chat. Okay, and now I'm really, again, thrilled that Natisha is joining us this evening to share more about her experiences of being affected by IBD and her story. So thank you, Natisha, for being here, and I'll pass it off to you.
Gotta start with unmuting, right? Thank you, Sarah. Hi, everybody. It's such a pleasure to be here to share my experience living with IBD. As mentioned, my name is Natisha, and I currently volunteer as a peer support mentor with Crohn's and Colitis Canada. Today, I will be sharing how I went from having significant distrust towards the medical system to an empowered patient who finally took reign over her own health. I experienced IBD symptoms for the first time in 2008, but at this time, I had no idea what was going on. My family doctor referred me to a pediatric specialist, and when I explained to the doctor that I was losing blood, had severe abdominal pain, a lack of appetite, and frequent and urgent bowel movements, he told me I was exaggerating my symptoms, and he sent me home while recommending that I simply take Imodium. It was in this moment when my initial fear and distress started to set in. I was dismissed by this doctor, but because he was a doctor, I thought he was probably right, and so I followed his advice. I bought Imodium and tried to manage my symptoms at home. 1 week later, my symptoms had really taken a turn for the worse, and I had lost over 15 pounds, and I was extremely lethargic. At this point, I was rushed to the emergency room in Kitchener and then was sent to McMaster's Children's Hospital in Hamilton, Ontario. I spent nearly 2 months in hospital, and after weeks of tests and multiple trials and errors with medication, I was finally diagnosed with severe indeterminate colitis. The diagnosis was very confusing, and I barely understood the medical terms the doctor used to explain what was happening to me or the severity of it. The name itself, indeterminate colitis, did not make sense to me. I was sent home with 2 medications, Imuran and prednisone, and after a long 6 months, I was finally in remission. 2.5 years later, I was hospitalized again with a severe flare after experiencing side effects to Imuran. The gastroenterologist who was on call came to visit me and told me I needed to start on biologics. I didn't know much about biologics at the time, but the thought of being on biologics scared me. I recalled seeing Humira commercials on TV that listed the many side effects, like lymphoma. When I spoke to the gastroenterologist about my concerns, she told me I had no choice, and she showed me a pamphlet and said, if you don't take medication, here is the percentage of IBD patients who are diagnosed with colon cancer yearly. By the end of the conversation, she told me if I chose not to take medication, there would be no reason for me to see her in clinic anymore. I remembered leaving that appointment feeling disheartened and feeling like I had no choice but to say yes. Otherwise, I would risk not having a specialist. This was my second experience where I felt like my voice and concerns were not being heard or adequately addressed. In my early to mid-20s, I had difficulty staying in remission because my body would produce antibodies to the biologics, which would lead to severe flare-ups and eventually hospitalize me. At this point, I was being treated in downtown Toronto by a new gastroenterologist. This gastroenterologist paired my new biologic with another medication called methotrexate. This was to help prevent developing antibodies to the new biologic. Given that my flare-up was so severe and I had almost needed surgery during my hospital stay, I agreed to this treatment plan. I still did not like the idea of being on so many medications, and based on my experience with previous medications, I was scared of the side effects. With methotrexate, I experienced significant hair loss. I had to take supplements such as folic acid to combat some of the side effects, and I had to avoid getting pregnant while on this medication. Over time, I had medical professional making comments such as, you don't want to be on methotrexate too long during your childbearing years, but I never really understood why. I stayed on the medication combo for many years, and I did achieve and maintain remission. I was finally happy to be living flare-free and a normal life. However, as I approached my late 20s, thoughts about my fertility were still weighing heavy on my mind and heart. Even though I was not ready for kids at this stage, I seemed to think about it a lot. I wondered what pregnancy would look like on Stelara, the biologic, and I wondered what would happen if I stopped methotrexate and then ended up flaring. This topic also became a subject in my relationship, and I recognized I did not have all the answers. I knew I had to speak to my gastroenterologist and get the answers to these questions. But based on my past experience, I was scared to have the conversation and to be perceived as a difficult patient, or worse, left with no gastroenterologist. After a few years of being flare-free, I eventually mustered up the courage to ask my gastroenterologist about making changes to my treatment plan and taking steps towards weaning off methotrexate and eventually the biologic. I shared with him my reasons for wanting to wean off the medication and how I wanted to have the comfort of knowing if I were to get pregnant, I could do so without fear or concern that I was on a medication that could impact that pregnancy. My gastroenterologist did voice concerns about me coming off medication because I had developed antibodies to the 3 previous biologics I was on. However, he was still open to making changes to my treatment plan. He recommended that we first do tests, which included colonoscopies, blood work, antibodies testing, and the FCAL testing. This was to ensure that ahead of weaning off any medication, I was in the most optimal state to tolerate any changes. To my surprise, my gastroenterologist said if I were to come off medication, I would need to be monitored more frequently. And to this present day, we continue to monitor my health via quarterly blood work, annual colonoscopies, and regular checkups. My gastroenterologist also connected me with another specialist in IBD and fertility to walk me through the process and explain any potential risks associated with weaning off all medication ahead of pregnancy. This IBD specialist recommended I stay on biologics even throughout my pregnancy because of my past flare-ups, but she assured me that the final decision was up to me. Overall, I felt a huge relief with not only the outcome of the conversation, but also how open the doctors were to hearing me out. I decided to stay the course with my biologic, but I weaned off the methotrexate. I was happy that the new treatment plan was working effectively for me and still is to this present day. Coming off methotrexate helped alleviate my concerns surrounding pregnancy and allowed me to focus less attention on my fears and more attention to living a normal life without these underlying concerns. I also find that I have more confidence in my medical team and knowing that I have a voice when it comes to my health and the outcome of my life. It's a relief to know that whenever I'm ready to have children, I am able to do so without having to rigorously plan or strategize for it. I shared a lot from my journey with IBD today, but the piece I hope you take away from this is that as patients, we sometimes have no choice but to advocate for ourselves. To end off, I will share 4 tips that help me feel more empowered when it comes to managing my IBD. Number 1, if you're nervous about having conversations with your gastroenterologist, it may be helpful to discuss with a family doctor or to reach out to Crohn's and Colitis peer support program. 2, it can be helpful to learn the basics of IBD treatment by getting clarification on certain medical terms, tests, test results, and what this may mean for you and your treatment plan. 3, it can be powerful to understand the way your disease works, and this can be done by keeping a journal of symptoms, tracking emotional states, and triggers such as food or stress-inducing events. And number 4, following studies like the GEM project to learn more about new outcomes and advancements in IBD research. We must remember that our specialists have one objective, and that is to keep their patients in remission. But these tips I've shared can help us navigate conversations with our medical team and empower us as patients to be part of the conversation when it comes to our health and treatment plans. Thank you.
Thank you so much, Natisha, for sharing your journey with us. And those were some really wonderful tips at the end for the group. And we'll be sure to share those tips along with the recording when we send everyone the email, because those were great. And the importance, again, of having those conversations. They're tough conversations to have, of course, but they're important when it comes to advocating for your own health. So thank you, Natisha. And thank you again, Ian and Barbara, for being with us here. We will move into the Q&A period now. There were lots of great questions that were asked ahead of time when everyone registered for the event. So we'll sort of try to prioritize those questions, and then we'll also try to get to as many questions that were asked during the live event now. And if you do have a question as we kind of go through this Q&A period, again, you can put it into the Q&A box. And if we don't get to your question, please do email us at learn@crohnsandcolitis.ca, and we can follow up with you directly. Okay, so we will get started with the first question for today. Thank you. So this will be for the panel. Perhaps maybe first we could start, Barbara, maybe with you, and then followed by Ian and Natisha. So do you have any recommendations or tips for getting better sleep when living with IBD?
There are, and some of them are sort of generic sleep hygiene. So turning off technology, within an hour of going to bed. We've all heard these, I'm sure. Cell phones, television, computers. Listening to relaxation podcasts or music, mindfulness exercises. I mean, those are some of the more generic, general recommendations. More specific recommendations, let's say you're somebody who gets up numerous times throughout the night for bowel movements. Looking at ways to minimize that is really important. Utilizing Imodium at bedtime, as long as it's safe in your particular situation, to help reduce stool frequency at night. Because we all know if we're getting up 3, 4, 5 times at night to go to the bathroom, we're exhausted in the next day. So looking at strategies to reduce stool frequency at night, maybe using cholestyramine, so Colestit, Questran, Olister at bedtime to reduce stool frequency through the night. That's all I can really come up with right now. The other thing is, if you have an ostomy, there are larger ostomy bags that people use at nighttime, making sure that there's a valve on them for gas release. I think that's all I can come up with right now.
Great. Ian, anything to add?
I'll just add that, of course, I agree with everything Barb said. She's fantastic, and we're so lucky, as I said, to be on this panel tonight and to have Natisha and Barb. And Natisha, thank you so much. It's an honor to hear your story. And but your story, I think, highlights some of what Barb and I were talking about, which this question highlights too. Is it really is individualized. And so Barb, I think, just did an eloquent job of saying there is no one size fits all solution to this, and you need to troubleshoot what's keeping you up at night. And if it's diarrhea, as Barb said, there might be some issues. If it's generic insomnia related issues, there may be some general sleep hygiene things. So it really depends on the scenario. I like, one of the common things we face is that urgency and need to wake up during the night to go to the bathroom, and that might be what's kind of buried in this question. But that's only one of the issues. It might be stress that's waking you up at 3 in the morning. I know that's what wakes me up at 3 in the morning. So the approach really depends on the individual. Barb, everything you said is true. The only extra thing I might add is for urgency symptoms in UC or proctitis, more limited, that's one of the places we sometimes use rectal therapies as well. So I didn't talk about that so much in my talk because it's a high level overview, but to the point, it's individualized. So if as an individual you have urgency that's due to inflammation right near the opening, we sometimes will add in a rectal therapy, and an hour or 2 before bedtime might be a good time to use it so that you're not up all night. And that might be a suppository or an enema or something that you take. So classically, we would often prescribe those in the evenings or before bed. Might be nausea or vomiting or reflux that wakes you up at night. So you might need anti-reflux medication. It really depends on the scenario.
Thank you. And Natisha, is this something that you've struggled with yourself? Do you have any advice?
I've definitely struggled with this when I'm in a flare. Things that helped me were one, a timing when I would eat before bed. So I would generally try to eat earlier into the evening versus later, just to avoid having to get up multiple times in the night. It may not stop you from getting up multiple times in the night, but it may lower the amount of times you are getting up. And of course, I have my handy dandy heat pack, whether I'm in a flare or not. It seems to help with any abdominal pain that I might face in the evening time. So if you can tolerate the heat from a heat pack, sometimes that can add some comfort.
Yeah, those are great suggestions. Thank you, Natisha. And maybe just to add on to your point about abdominal pain, I know when the organization has done some needs assessments in the past, we find that abdominal pain is actually one of the most frequently reported issues. And Ian, Barbara, do you have any sort of suggestions or options that you can share when it does come to abdominal pain, if that is something that's interfering with sleep or causing fatigue or just general discomfort throughout the day?
I think I can go first, and then Barb can chime in. We'll reverse the order, but and then we can tag team back and forth.
Thank you.
Half hour goes on, but it's going to be the same theme for every answer. And I've been looking at some of the ones that are posted in the Q&A as well, and the same theme is it depends on the individual situation. And so I think often, like I said, if there's abdominal pain, it might trigger us to investigate what the cause is and try to treat the root cause, because the treatment for the pain may really depend on what's causing the pain. And so if you're in a flare and it's inflammatory, the treatment might be focused on anti-inflammatory type medications. Whereas if it's altered bowel habit, it might be altered, like if you're constipated, or you might be trying to treat that and just get you to moving it again. And if it's more of a manifestation of stress or irritable bowel, we may target our treatments on that. So it depends. And in general, there is not, therefore, a quick answer to that question of like, take this painkiller, you'll feel better and your pain will go away. In fact, painkillers are often some of the least effective management strategies for management of abdominal pain and inflammatory bowel disease, outside of the very like acute, I just had surgery situation. And the reason is they don't really get at the underlying cause. And so we need to figure out what the underlying cause is and try and sort that out and target our remember my slide with the 4 different strategies, target our medications, our diet, our lifestyle, and our wellness management strategies around mental health towards the management of the pain. So long story, I don't have a single pain management strategy. You have to talk about it, track it, and then work with your team to get to the bottom of it.
Okay. I think I would agree with all of what you said there, Ian. Pain is so individualized, and how each person perceives pain and experiences pain is so different. And as Ian said very eloquently, the root cause of that pain has 100 different sources that we could probably list off on the top of our head. So it really is important to discuss the pain, talk about it in your appointments, try and figure out what the root cause of the pain is, treat that, and then work from there.
Okay, thank you. Next question, please. Okay. What are some new or longstanding management strategies that are still, relevant today to consider in older adulthood for a person who has been living with IBD since their early adulthood, so they've been living with IBD for a couple decades or a few decades?
That's a great question. I was just part of a research study that looked at the perceptions and care of persons with IBD over the age of 60, I think was the cutoff, the early cutoff. But what I love about the way we practice inflammatory bowel disease care is that there is no ageism in my practice. And I know Ian practices the same way. It doesn't matter if you're 20 or if you're 80, you need a reduction in your inflammatory burden with the most effective treatment possible. There are a couple of exceptions in treatments. We use Imuran more cautiously in people over the age of 65, just because of the increased risk of lymphoma. But really, we treat anybody in who we would consider an older adult very much in the same category as everybody else in reducing their inflammatory burden. Treatments are safe. Some of the clinical trials don't have huge populations of older persons, so it's sometimes a little difficult to extrapolate the trial data. But the treatments are quite safe and effective, the biologic therapies. So we wouldn't hesitate to use them in an older person. I have a 92-year-old on biologic right now. So, you know, I love that question because I think it's important to know that older people are being presented with most of the same treatment options as the younger patients. So, Ian, maybe you can add something more to that. But
another theme besides the theme of it has to be individualized, another theme you're going to hear is I agree with Barb with everything she says. So that's the other theme.
You're funny. You're funny,
Well,
Ian.
it's the truth, though. It's easy to be funny when it's true. But, Barb, 99, I had a patient who was 99 who I started on biologics for ulcerative colitis. So the strategy is not necessarily different. I think the question buried here is like someone who's had it for a long time. In the person who I had diagnosed with 99, they were diagnosed at age 99. So they, with a hospitalized flare, like not dissimilar to your story, Natisha, that you had when you were a teenager, this individual had when they were 99. So we see it at every single age, from very young to very old. In someone who's been living with it with decades, the management strategies, therefore, like Barb said, don't necessarily change. Buried perhaps in that question, if I'm reading into it a bit, is, someone who's been in remission for a long time, and is there the potential to de-escalate? It doesn't say that there, but I'm reading into it that might be what the author of this question might have been thinking. And yeah, there might be a potential for someone who's been in deep remission for a long period of time to go through staging and to talk to their team and to see what's going on and to potentially de-escalate therapy. So there is something there that we are doing, but that's for people that have been on it in remission for a long period of time, not necessarily for a new diagnosis. Essentially, that would be treated the same, other than some mild caveats like avoiding the immunosuppressant azathioprine, like Barb said. But otherwise, you're 16 or you're 99, you probably more or less get the same treatment algorithm.
Okay, thank you. There was a question that came through just during the talks now, somewhat related. It's about risks in older adulthood and sort of the relationship with IBD. And they were specifically asking, is there a link between IBD, obviously, because of prolonged chronic inflammation, and the risk of dementia or cognitive impairment?
I saw that, and I think that in general, I'm going to say those are separate entities. And so no. And so I think in general, they're like dementia and IBD are not related diagnoses. I will say, like, wellness, it's important to live a healthy life, and reducing your inflammatory burden over time is going to be good for every part of your body, including your brain. So let me say, put that out there, is, there is interest in studies and research and some emerging evidence that all diseases may be related to like inflammatory states in your body, and dementia is one of those that has been implicated in like inflammatory states that go on for years, are not generally good for you, and might be a link to risk of dementia. But it's not a cause and effect, if you know what I mean. Like dementia is not an extraintestinal manifestation of inflammatory bowel disease. So in general, we want people to be healthy and have a low inflammatory burden and minimize the overall impacts on their health and quality of life. And then there might be some spin-off effects of like minimizing your risk of things like dementia in the future, but in general, not a specific cause and effect.
Okay, thank you. So I think for the next question, I'll go over to Natisha. There was a question again from the audience, and then we'll move on to the next slide. But Natisha, someone mentioned that they are supporting a family member. They are a family member, and they're supporting someone that's been newly diagnosed with Crohn's disease. And so how would you, as a Crohn's disease patient, feel about having discussions about the subjects in the PrEP guide? Like, how would you feel using the prep guide and having and approaching those types of conversations? And would you encourage family members that may not have IBD to share that with their loved ones?
Yeah, of course. When I saw that prep guide, I wish I had that back in 2008 when I was diagnosed. In fact, when I was diagnosed, there was very little information and very few medications that they were using at the time to treat Crohn's or colitis. So I would say that would be a good stepping stone and a good place to start to kind of explain what's going on. And again, I think the big piece that I appreciate about that form is the mental health piece. That piece, I think, drives a lot of the conversation because again, as the doctor said, it's connection. So your brain to your gut, to your brain to your gut. And so if you're not feeling good up here because of what you're experiencing, it's just going to be a continuous loop. So I think that would be a good way to start those conversations. One thing that helped me explain to my close families and friends is something that can be researched. If you Google the spoon theory, this was basically somebody who's explained that every time that they were in a flare up or felt ill, any small task that they did would require spoons. So say you have 10 spoons that are given to you, one would be taken away for every task. And say you only had 10 spoons for the day. By the time you're done and it's 10 a.m. and you've gone from brushing your teeth, showering, doing your hair, doing your makeup, eating your breakfast, you're pretty much done with your spoon. So you basically have no energy. And when I use that concept to explain to my family and close friends of how I was feeling and what I was experiencing, it really hit home to them and they could really use that in their own life and apply that. So I think both in tandem could be very, very helpful.
Yeah. Yeah, that's a good analogy to try to help express that fatigue and then help them understand the impact it has, for sure. For sure. Thank you. Next slide, please. Okay, I feel like my healthcare provider did not find the best medication option for me. How can I bring it up with them? Barbara, we'll start with you.
Sure. I think a lot of this question for me centers around the fact that we don't know, we can't predict exactly how a medication is going to respond or how a person is going to respond to a particular medication. In the future, it is my hope that we'll have the ability to predict which patient is going to respond to which treatment. So for now, we base our treatments on the best possible evidence, the safety data, and the best fit for a particular patient. Most of our medications that we have, 30 to 40% best chance of remission. That's a pretty good opportunity to get well, but at the same time, what if I don't respond? So I think for me, the most important thing for me to know when a patient's not responding is for them to understand what our target is and how long we're going to wait to achieve that target. So, blood work, symptoms, fecal cal. When are we going to rescope if we're not seeing improvements in those targets? And how are we going to know then where do we go from here? So I think that how can I bring this up with them? It's helping your care provider, your specialist, understand your response to treatment. So when you're going back for your appointments, this is how I felt when I first had my treatment. This is how I'm feeling now in my maintenance phase. I just did my fecal cal. And just to throw it out there, nobody likes doing fecal cal. Nobody likes to collect their poo. But the bottom line is, aside from a colonoscopy, it is the best non-invasive tool that we have to assess disease activity. And I know we harp on it, and I know we harass our patients to get it done, but it's because we really don't want to have to put you through a scope if we don't need to. So I'll give you an example here. I have a patient who had a very high fecal cal, 3,000. She went on a biologic, and her symptoms, stool frequency, consistency of stool, didn't change much. but her fecal cal went from 3,000 to 200. So helping her understand, and she wasn't buying the fact that this drug was working. Well, my stool consistency hasn't changed. I'm still going X amount of times. This drug isn't working. So being able to show, well, you know what, I appreciate what you're saying. However, it is reducing your inflammatory burden. So maybe now we can take a step back and look at maybe some other causes of your looser stools. So just knowing what the targets are, knowing what to expect, knowing, you know, how long should I wait to see if this medication works, and then bringing it up, well, I'm concerned that maybe this medication isn't the right one for me, or maybe I'm not responding as well as we had hoped. Ian, thoughts?
Again, 100% agree. And I'll just add in, like, on a simple level, if you think there might be a better medication, or you want to switch, you know, just ask. And I know that's hard. I know that appointments can seem rushed, and not every practitioner may seem as approachable as I like to think I might be. But even for me, I'm sure I have patients you speak to who would say, oh, I don't feel comfortable asking him. They should, but they might not. I get it. So the other technique might be to, you know, use the office, like the admin, like the secretary, maybe call them ahead of time and say, I want to talk about this drug before my appointment. Email or mail something in. Say, like, I found this on the Crohn's Colitis Canada website. I want to talk about this. So give the person a heads up if you're a little nervous to bring it up. I say you shouldn't be nervous to bring it up, like it, but I get it if you are. And so if you are, and you're like, I don't think I'll be brave enough to bring it up to this person in this appointment that I want to switch to this drug, then maybe ahead of time just call the secretary and say, I'd like to speak about this drug in this appointment. Here's something I found on Crohn's Colitis Canada. I want to talk to the doctor about Stelara. I'm on Remicade. I want to talk about Stelara. That's just an example. I'm not pushing Stelara, but you could give the person a heads up ahead of time. Personally, I'd appreciate it. Like, I want to know what questions you want answered. So just ask me.
Okay, that's great. Natisha, I know you mentioned earlier, you know, having conversations around kind of weaning off of methotrexate and other medications. Do you have any sort of additional advice for someone who may be struggling to have this conversation, or maybe even receiving some pushback from their provider?
I would say from my experience, the first approach that I took was just saying I didn't want to be on medication because I was scared of the side effects, but I didn't really go into what those fears were and really diving into it. I just would say I don't want to be on medication because, for two reasons. For me, when I started in 2008, there was really only two treatments, at least for the hospital that I was seen at, that was available, which was Remicade and Humira. I had gone through Remicade, and I was young at this point. I was 18 years old, and I have a whole life to live. So I always thought, okay, if I run through Humira, what does that mean? If I develop antibodies to the Humira, what does that mean? Does that mean that I'm automatically going to be getting surgery? So those were the fears for me, which I didn't get to add in the detail for time, of why I wanted to come off medication. I wanted to prolong that, and I wanted to see what I could manage, maybe with prednisone and whatnot. So I think it's really explaining to the physician what your fears or challenges are and working with them. And as Barbara said, sometimes there is change happening in the background. We just don't see it. So like for the example, the CRP levels, you know, that going down, you may not see that change in the symptoms, but they're seeing it in the blood work. And us as patients, we don't always understand that. And that's where tip number 3 comes in from my speech. And that was, you know, understanding these tests, understanding those results and what they mean. So sometimes then you can look at it and you can see exactly what's happening.
Yeah, no, that's really important. Talking about the fears, like what's the source of, like, you know, what the medication concerns are, for sure. And again, the conversation guide can be a place where maybe someone talks, or, you know, kind of lists out some of those fears or concerns that they have before their appointment. Thank you. Let's go to the next question on the slide, please. And then I think we'll probably have one more question afterwards. Okay, so why do I feel, and maybe I'll broaden this out to both Crohn's disease and ulcerative colitis, but why do I feel fatigued even when my IBD is in remission? Ian, we'll start with you, and then followed by Barbara.
You can probably guess what I can say. It depends on the scenario, because it's potentially a lot of different reasons. And so Maybe you're not in remission. There's one. Maybe you have an anemia or a vitamin deficiency or something like we said we need to look into. Or maybe you're having trouble sleeping, or maybe there's mental health concerns that give you a feeling of fatigue. Maybe your thyroid's off. So really, it's something not to ignore and to chat about, because there may be some simple questions around your overall health, mental health, and some simple blood tests to try to figure that out. In the absence of anything being found, because that's a scenario we do see, like we check all that stuff I just said and we literally can't find anything. Sometimes a chronic disease, like even if it's in remission, it's not cured. There's no cure for Crohn's and colitis. And so we aim for deep remission where you like live a normal life. But there are some lingering effects. And so sometimes you never completely goes back to normal. And that's not to take away, we want to finish on a positive note tonight. That's a rare circumstance. And that's why I'm saying don't just take it for granted. Get it investigated. Let's make sure you're actually in remission, make sure there's nothing else going on. But there are some patients that do live with a degree of fatigue with chronic disease that we, which there's still strategies for managing, but that is part of it.
And Barbara, did you have anything to add?
Yeah, I was just, we recently ran some virtual ACT therapy, which is acceptance commitment therapy, similar to cognitive behavioral therapy, in a group of people with inflammatory bowel disease, not necessarily those with extremely active disease or in a flare, but it was a group of people who volunteered to participate in this session. And one of the overwhelming symptoms that were common amongst most of the participants was fatigue. And as it was explored in more depth with the psychologist, as Ian mentioned, fatigue is so multifactorial. But what some of the patients recognized was it was mental fatigue. Fatigue of living with a chronic illness, maybe not enjoying some of the activities they used to do, the apprehension related to leaving the house, concerns over having a bowel accident. All of these real challenges were taking a toll on the person's overall physical and mental health. And when some of that was teased out and over the course of 6 weeks, people tried to dive into that a little bit more, get out of their comfort zone a little bit, go out and do a few more things. And they found that their fatigue was less. It wasn't gone, but it had minimized somewhat. So as Ian mentioned, it's so fatigue is one of the it's like headache. It's very difficult to tease it out and to come up with a concrete strategy to deal with fatigue. Once you've ruled out, and we see this a lot, you've ruled out all the organic causes of fatigue, and you're left with, fatigue of chronic disease, I think, at the end of the day. And there is some studies going on. Actually, one of our past Can IBD nurses, she's a PhD now, and she did her dissertation on fatigue and IBD. Oh my gosh, her name is just escaping me right now. It'll come to me. Irina Nestor. So if you Googled that, Irina Nestor, Nestor, I think, you probably find her study. But I'm fairly sure her study was on fatigue and IBD. Maybe we can even find it and put it in the chat. Yeah.
Yes, thank you. Thank you so much. Yeah, and I think we might have a copy of the paper, the research that she did. I think she also looked at discomfort and pain as well, Barbara. So for sure, we'll try to share that here, and if not, we'll share any additional resources that were mentioned this evening in the email tomorrow when we send a link to the recording. I am mindful of time. It is 8:30. I think some of you mentioned that you might be able to stick around for a couple more minutes. So I'll ask one last question And mainly because Natisha kind of alluded to earlier around running out of options. And Barbara, you kind of mentioned it as well. And so, if someone has sort of tried most of the options available to them, at what point does surgery become part of this conversation? And should patients be bringing up surgery earlier on in these conversations, even if they maybe haven't kind of tried sort of the last medication option that they may have available to them? Ian, if we could start with you and then follow with Barbara.
For sure. And well, last question. I'm glad I stayed for a few minutes longer because it depends, right? And so surgery is not necessarily in the treatment algorithm where you go to for treatment failures. For certain presentations, like complications of Crohn's disease, we didn't talk about, where it penetrates through and causes an abscess outside of the bowel or a fistula or something like that, surgery might actually be the first step, like early in the treatment algorithm. So it depends on the presentation and who you are, what your symptoms are, what you're experiencing, what your disease is, and how it presents and what complications you have as to whether surgery might be appropriate for you or not. And yes, it's always something worth asking about. It's always something that your team is probably thinking about. And so therefore, if you're curious, just ask, like, wait, couldn't surgery help me with this? And as I said, if you have an abscess, you'll probably need a surgery quite early. In terms of surgery as a last resort, which is what you were asking about, we've tended to move away from that actually these days because we have so many treatment options, and think more about surgery as just doing it when it's appropriate, not because you've failed with everything else. And even in patients that do go on to surgery, that's not a cure. There's no cure for Crohn's and colitis. And so it's part of the treatment algorithm. And after surgery, most patients post-operatively, 3, 6, 9 months later, are getting rechecked. And if there's any signs of early inflammation, going right back on a medication. And so I know you were saying, like, oh, if you've tried 3 medications, you should go to surgery. No, that's not the way it is. If you've tried 3 medications, they're not working, there might be a 4th or a 5th or a clinical trial we could go to or something. So surgery is more something to think about when it's appropriate, and it might come in at any stage.
Barbara, anything to add?
No, I agree. I think that surgery is an important tool in our toolbox. And it's very important to have those conversations early with patients, particularly around, temporary ostomies, to help heal perianal disease, colectomy for severe ulcerative colitis that's not responding to treatment. And, the patient is running risk of a perforation of the bowel and becoming more, quite sick. Stricturing or scarred down Crohn's disease. Absolutely, there's a role for surgery there. No treatments are going to heal scarred tissue. So there is definitely a role in understanding, as Ian said, understanding what that role is and what it would look like for a particular patient is very important. And knowing that outside of medical management, sometimes there are surgical options that could provide symptom relief. But again, like Ian said, there is no cure for Crohn's disease. And, we want to minimize the amount of particularly the small bowel that's resected, because we don't want the patient to develop nutritional complications. Ulcerative colitis, yes, people lose their colon and go on to live healthy lives with an ileostomy or with a J-poach surgery. But again, those are not without their own risks. And it's important to know what your options are always as a patient.
Yep, for sure. Okay. Well, it's 8:35, so thank you all for sticking around a little bit longer to answer a few more questions. We appreciate it. And thank you everyone in the audience for joining this evening. If you do have any more questions, or if something wasn't clear, or you need any sort of further support as you kind of navigate your journey of living with IBD, please do email us at learn@crohnsandcolitis.ca, and we will follow up with you there. I think there's just a couple more closing slides here. Okay, so we do have a poll question. So now that we've kind of gone over some of the key management strategies of IBD. How would you rate your current knowledge of management strategies for Crohn's disease and ulcerative colitis? So again, this is a similar question as what was asked at the start. So if you want to rate that on a 0 to 10 scale, again, no right or wrong answers, but it's important for us to know if the information this evening that was presented was helpful in improving your knowledge on this particular topic. Okay, so a few more moments. I see most of you have responded. So Lucia, I'll leave it to you to end. Okay, perfect. Okay, so it looks like there's definitely a trend here of going upwards, closer, more individuals rating anywhere from sort of a 7 to a 9. So that's good. That's encouraging. So I'm glad to see that most of you are reporting. Some of you still reporting some maybe concerns there around knowledge around management. So again, do email us at learn@crohnsandcolitis.ca, and hopefully we can kind of help clear up some of that for you. Next slide, please, Lucy. Thank you. Okay, and this is pretty much wrapping it up. So I mentioned in the chat earlier that there is a survey. It's going to appear to you when you end or you leave the Zoom webinar. There's only a few questions there. Shouldn't take you longer than 60 seconds. We do look at every single piece of feedback to know, what went well, what could be improved on. There will also be a few questions about the conversation guide. So we really would appreciate it if you take the time at the end to complete that survey. Thank you very much for your time. And I believe that should close it off for this evening. So thanks again. Thank you, Ian, Barbara, Natisha. Really appreciate you all taking time out of your busy schedules. And again, thank you